Hello, my name is Chuck Varnell. I'm one of the nephrology faculty here at Cincinnati Children's, and I'm going to talk to you guys today about chronic kidney disease. So this will be the outline of what we're going to talk about today. So I'd like to start by talking about the GFR, the glomerular filtration rate. There's a couple ways that we can check this in children. So there's the measured GFR, which is either a 24-hour urine collection, or we can do it with radiologic methods using nuclear medicine. Additionally, the ones that you're probably more familiar with, the creatinine-based eGFR, cystatin C-based eGFR, are actually estimated GFRs, but here's the formula for the bedside Schwartz equation. So whenever we talk about kidney function, how much kidney function does somebody have, what we're really saying is what is their GFR, their glomerular filtration rate. So how does that relate to chronic kidney disease? So chronic kidney disease is a state of irreversible kidney damage and or reduction of kidney function, or GFR, that can lead to future decreases in kidney function. This really is more of a spectrum than really a discrete point in time. So renal dysfunction itself is a continuum. And you can see on this chart here, the blue dotted line on the top is just a bunch of healthy subjects and what happens with their GFR over time. And generally, when you're young, it stays normal. But in children with chronic kidney disease, so if you're born with hypoplasia or dysplasia, you'll have periods in your life where you can have rapid decline. So these happen particularly during periods of rapid growth. So the first growth spurt between 2 and 5 years of age, and then again at puberty, are new stressors that your body can put on your kidneys where you notice a rapid decline in GFR. And what I'll explain to patients is your GFR is not actually changing. You always have the same amount of kidney function. But because you have reduced kidney function, as your body creates more demand on those kidneys, it'll measure as decreased kidney function over time. So when we look at the definition for CKD, KDIGO, or the Kidney Disease Improving Global Outcomes Group, is one of the big groups that puts out a lot of clinical practice guidelines for nephrology. And they defined it as either a GFR less than 60 mLs per minute per 1.73 meters squared for greater than 3 months with implications for health regardless of whether other CKD markers are present. So a wonderfully convoluted definition. Or a GFR greater than 60 that's accompanied by evidence of structural damage or other markers of kidney function, including proteinuria, albuminuria, renal tubular disorders, imaging problems, or problems on biopsy. Once we know what your GFR is, we'll stage you into multiple different categories. So when we think about what the epidemiology of chronic kidney disease is in children, far and away, congenital anomalies of the kidney and urinary tract, or CACUT, is the majority of the patients we take care of, so almost 60%. About another 20% or so are glomerular diseases, such as FSGS, and then the other 25% is just the kind of smattering of everything else that we'll take care of that's not very common. So a fair amount of it actually can be unknown, or we don't ever really figure out why you have chronic kidney disease. There's some hemolytic uremic syndrome, HSP, various genetic problems. In the United States, the incidence of ESRD is 2 to 3 times higher in African American children compared to Caucasian children, and we know that all ages are affected. So throughout childhood, you can see it's almost pretty, not evenly split, but it's mostly evenly split between all age groups. So 20% less than 2, 30% 6 to 13, and so on. We do know that the incidence and prevalence of CKD is greater than males, 2/3 of males compared to 1/3 of females. The question why comes up quite a bit. And you can see here in this voiding cystourethrogram, this is somebody who has posterior urethral valves. So that's a large part of chronic kidney disease in children. It's a large percentage of the children we transplant are born with posterior urethral valves. The arrow that's pointing down here is pointing to the actual valve itself. And so behind it, what you see is a very large and towering bladder that's just because of all the back pressure. The problem with chronic kidney disease is it is a progressive disease. So once you have chronic kidney disease, we know that it tends to get worse over time. And this chart tries to show you why. So if we start in the middle, with reduced nephron mass, that leads to glomerular hyperfiltration, which can lead to proteinuria. That proteinuria over time is both a sign of chronic kidney disease, but it's also a future cause of further chronic kidney disease. So that can cause tubular interstitial fibrosis that then feeds back and creates less nephron mass. That reduced nephron mass itself causes sympathetic hyperactivity, which can cause hypertension, which causes glomerular hyperfiltration, which again you can see goes through and can worsen proteinuria. Hypertension can also directly damage your kidney, and you can have reduced nephron mass that way. So I always try to explain to our patients, once you have chronic kidney disease, we do know it's going to progress, and our job as the nephrologist is to really identify what are the modifiable risk factors for chronic kidney disease that you have that we can control so that we can take that slope of progression over time and make it less steep. So we already talked about some of these. Some of the non-modifiable risk factors for CKD are age at onset. So obviously the younger you are when CKD starts, that's a worse prognosis because you're just going to have more time with CKD. The etiology, so certain things are less severe and less progressive depending on what disease you have. So FSGS versus a dysplasia or an obstructive uropathy, if you're able to fix some of those, sometimes you don't have as bad progression. The age at which you go into puberty, again, not necessarily that your kidneys get worse per se, but the demand your body's putting on those kidneys becomes unmasked. And then other polymorphic genetic variations. So things that we can potentially control that'll have a positive outcome and reduce the progression of your CKD are blood pressure control. So knowing if we can keep your blood pressure under optimum control, patients with better blood pressure control have slower progression of their CKD, and that's been shown in studies. Proteinuria, if we can control your proteinuria below certain thresholds, we know patients with less proteinuria tend to do better than patients with more proteinuria. Your acidosis status, if you're anemic, your calcium and phosphorus, all those are things that we can affect with medication that can help with your CKD. And I included this link here in case anyone wants to play with this calculator. There was a study by Dr. Firth and colleagues that looked at patients with CKD, and you have to put in what their current GFR is, how much protein they have in their urine, and whether they have a glomerular or non-glomerular cause of CKD. And this calculator will actually give you a prognosis percentile. So, for example, the example that's here, for the variables that were set, it shows you that the 50th percentile time to ESRD was 6.2 years. So it's very helpful for us to be able to have calculators like this so we can talk to families about, is dialysis in your future? Is it in the next couple of years? Do we have to start thinking about kidney transplant? So it's helpful for a planning standpoint. So here's a list of other complications of chronic kidney disease that we'll go through in more detail for each one of these. So for electrolytes, the first one that everybody probably thinks of, and at least in the hospital is the most worrisome, or outside the hospital as well, but you probably experience more of it inside the hospital, is hyperkalemia. So acutely, what do we do to manage hyperkalemia? If it's an emergent setting and somebody's hyperkalemic, you want to get an EKG stat, and you want to give the patient calcium, bicarbonate, albuterol, insulin, or glucose. Obviously, you want to do this talking with your nephrologist to make sure which one or all of these that you do. But these are essentially going to buy you time, right? So these shift potassium into the cells while you're trying to figure out how you're going to get rid of the potassium. The things you can do to actually get rid of the potassium are use Lasix, which works very well if your patient makes urine, which not all of ours do. K-Xylate you can use as needed. We don't like to use this medication a lot, but in the acute setting, it works. And dialysis, if it's a patient who already has a dialysis line and is already on dialysis, getting dialysis started emergently can be very helpful. More chronically, the mainstay of hyperkalemia management is dietary management, so trying to avoid sources that are rich in potassium. Unfortunately, in addition to potassium avoidance, we're going to talk about phosphorus control, but that's another way that we would have you avoid phosphorus exposures through your diet. If you try to look up what foods are low in potassium and low in phosphorus, you're starting to get to a pretty severely restricted diet. So some of this we kind of have to deal with and mediate it as best we can, because a lot of these are actually pretty healthy for you outside those McDonald's French fries that I have here on the screen. So another problem with chronic kidney disease is secondary hyperparathyroidism. So the way this works is the kidneys are in charge of eliminating the majority of the phosphate in your diet. The rest of it is through the gut. The kidneys convert inactive 25 OH vitamin D to active 125 OH vitamin D. And that vitamin D helps in the feedback loop for your PTH secretion. So an increased PTH secretion is stimulated by low calcium and high phosphorus. In the gut, PTH causes your gut to absorb more calcium and phosphorus through the active 125 vitamin D, and it's supposed to increase renal elimination of phosphorus. The problem is when you have chronic kidney disease, that pathway is still intact, so your body is sensing the phosphorus is up. You increase the PTH to tell your kidneys to get rid of the phosphorus, but your kidneys don't work. And so the phosphorus goes up, which then is a positive feedback loop on the PTH to keep going up. Long term, the problem with that is that your body, when your PTH is very high, it's going to start leaching calcium out of your bones. And so patients can have osteoporosis second to their secondary hyperparathyroidism, or they used to call that renal osteodystrophy or renal rickets, are other names that I've heard for that. The way that we can treat this, the mainstay is through dietary phosphate restriction, but again, if you look at foods that are high in phosphate, it's very hard to avoid in your diet. So other things we can do is give phosphate binders. So these are to be made while you eat, so you take them with meals and with snacks. The one we like the most is Tums because it's cheap and it works pretty well as long as the patient's not hypercalcemic. Calcium acetate is another one that you can give. The brand name's Foslo. And then there's non-calcium containing phosphate binders like sevelamer carbonate or Renvela. Those are for patients who tend to be hypercalcemic. You don't want to add more calcium to their diet. The other ways that we'll treat secondary hyperparathyroidism is with vitamin D, so both inactive as ergocalciferol and active as cholecalciferol. And then we can give calcitriol and paracalcitol or other medications that'll do that. In chronic kidney disease, there's problems with anemia. So there's a lot of reasons why patients with chronic kidney disease are anemic. So first, the kidneys produce erythropoietin. There's nutritional factors, so they can be iron deficient or B12 deficient. When patients' BUN goes up and they get more azotemic, they could have uremic effects such as a shortened red blood cell lifespan or platelet dysfunction. The PTH, when it gets elevated, interferes with erythropoietin's ability to work. Patients with CKD are in a chronic state of low-level inflammation. And actually, patients who have dialysis catheters in place, you can detect that in their blood that they have chronic inflammation, so that can be a problem. And then there's also non-renal causes that we need to remember too, like hemolysis or GI losses. Anemia is associated with increased mortality and morbidity, so we do try to aggressively treat it. And the way we treat it is if you're iron deficient, we have to supplement your iron stores. And then we start erythropoietin, so either as EPO, which is a 3 times a week formulation, or there's a weekly to every other weekly formulation, Aranesp, that we can use as well. The other thing that you could do is if somebody was anemic is you could give them a blood transfusion, but if you've ever cared for our patients, you know that we would like to avoid a blood transfusion at all costs if possible, knowing that that is a sensitizing agent against somebody's blood type. So you could potentially sensitize them such that it'd be tougher when it's time for them to get a kidney transplant, finding a match. Growth and nutrition is obviously a big problem in children with chronic kidney disease. There's a study from 2005, which was a very, very large study of the NAPRTIX database, which is a North American kidney patient database that found that a third of patients with chronic kidney disease have growth failure, so failure being height less than the 3rd percentile for age and gender. That was at the time of enrollment, so that's pretty significant. Growth failure is associated with age and CKD stage, and only about 17% of CKD patients had a height greater than the 50th percentile for age and gender at that time. The problem as a child with growth failure is you lose that potential. So from birth to 2 years, that's a very big time that you're supposed to grow, that if you have chronic kidney disease, you're not going to grow as well. And during puberty, if you have chronic kidney disease and we're not treating it, again, another big growth spurt that you're going to miss. These factors are also multifactorial. So patients with chronic kidney disease can have a decreased appetite, so they just don't feel like eating. If you're chronically acidotic, you can't grow very well. If you're chronically anemic, you don't grow very well. If your PTH is out of control, it's going to affect your growth. A lot of children that are born with CKD, for reasons that are not entirely clear to me, need G-tubes, so they just really don't have the oral motor skills. They're not interested in eating. They don't learn to eat normally, so it can take years of therapy to really get that figured out. If your dialysis is not sufficient, so if we're not giving you enough dialysis, you're not going to grow well. And then these patients are also growth hormone resistant. So we will prescribe growth hormone, which is a daily sub-Q injection to our patients who have growth failure to help them grow. And there's an example here of a patient that you can see had growth failure less than the 3rd percentile. And then at the time that they started growth hormone, over several years, they were able to get their height back on the chart. Cardiovascular disease is a huge problem with chronic kidney disease. It is responsible for almost half of all the deaths for patients who have end-stage kidney disease. So these are patients on dialysis or with a kidney transplant. There's a study from 2002 that looked at almost 1,500 pediatric dialysis patients, found that 31% of them had some sort of cardiac event. A quarter of them were less than 14, and 40% of them were teenagers. Those included arrhythmias, valvular disease, cardiomyopathy, and cardiac arrest. And we know that cardiovascular disease directly shortens the lifespan of almost 30 years of healthy control. So when I was in fellowship, one of the attendings I was working with told me that a dialysis patient who's been on dialysis for their life, who's now in their 20s, has the same Framingham risk factors as a normal 80-year-old man in the United States. So it's really significant what the cardiovascular disease is for a dialysis patient. So end-stage renal disease is when your GFR gets less than 15. This is permanent loss of kidney function, generally not considered to be compatible with life without intervention. And so those interventions for us are renal replacement therapy, either with dialysis, which can be hemodialysis or peritoneal dialysis, or a kidney transplantation. And we can do that either through living donation or deceased donation. This is just a picture of the two types of dialysis that you will commonly see in the hospital. For chronic dialysis, so hemodialysis is you remove the blood from the patient's body with a blood pump, you run it through a dialyzer or the filter, which has dialysate running countercurrent to the blood flow. Things that are in the blood that you want to pull out, you have low in your dialysate, and things that are low in the blood you want to put in, you put high in the dialysate, and then they just follow their concentration gradients across that membrane. This picture has somebody with a fistula as their point of dialysis access, so we have to find a way to be able to get to the patient's blood, and a fistula is one way to do so. The other type of dialysis we have is peritoneal dialysis, where you have a peritoneal catheter that goes from the outside of your body into the peritoneal space. We fill it with a dialysate solution, and then it sits for some period of time, and then you drain it out. And then the peritoneum itself actually acts as your dialyzer in that case, and that works pretty well. There's a lot of factors that go into deciding whether somebody would benefit better from hemodialysis or peritoneal dialysis. Sometimes it's lifestyle factors for the family, it's support that you have. Peritoneal dialysis is done by the patients and their families. They do their own dialysis, so you have to have enough home and social support to really do that well. Hemodialysis is exclusively done by a dialysis center, so all of your meds get done by the medical team. So you can imagine different scenarios where one might be better for different patients. So when is it the right time to initiate dialysis for somebody? I know on rounds it seems like everybody knows the AEIOU, and we can go through that. But really, it's a really difficult question clinically to ask. I think there's very clear cases when everybody would agree, yes, this patient definitely needs dialysis, and that's what this mnemonic's very good for. But when to start chronic dialysis in practice can actually be a little bit trickier. So acutely, definitely, if somebody has refractory acidosis, you've got electrolyte emergencies that you have to correct. Ingestions or inborn errors of metabolism. So a patient comes in with hyperammonemia, a baby, and you suspect an inborn error of metabolism. Ideally, you can get them on dialysis within a couple hours to rapidly get that ammonia down. If they're acutely fluid overloaded, if they are having symptoms of uremia, which is more than just a high BUN, because your BUN can get quite high and not actually have any uremic symptoms, but symptoms of uremia. And then why we have here, why aren't we feeding you? So particularly in young kids, if you're limited by how much nutrition we can give you because of your ability to pee or get rid of the fluid, starting dialysis would be a good reason for that. Chronically, again, uremia, but specifically symptoms of uremia, so decreased energy, you're not growing anymore. Sometimes we have patients with uncontrolled hypertension, so despite our best management with fluid restrictions and different medications, we can't get your high blood pressure under control, so dialysis would be a treatment for that. If you have uncontrolled nephrotic syndrome, some ways that we can treat uncontrolled nephrotic syndrome include nephrectomy of your kidneys, in which case you then have to go on dialysis, and poor nutrition and growth is another indicator for chronic dialysis. So again, I kind of made this point earlier, but when we talk about uremia, that is a clinical diagnosis. So azotemia is a term that just means you have a high BUN. So if somebody has an elevated BUN, you can say they're azotemic. If they are uremic, which you generally don't see at BUNs less than 80, so this is evidence of bleeding because of platelet dysfunction, altered mental status, things like that are more consistent with clinical uremia. If it's mild, it might be nausea, vomiting, fatigue, need for sleep. Again, severe is pericarditis, heart failure, excessive bleeding, and seizures. One of the other renal replacement therapies is kidney transplantation, and actually in children it is the preferred renal replacement therapy. So we know that a child with a kidney transplant compared to a patient who's on chronic dialysis has a better quality of life. It's less expensive long-term to the healthcare system to maintain a functioning kidney transplant than it is a patient on dialysis, and they have a significantly longer life expectancy. For our patients, we really try to be proactive about this, and it's actually better to receive a preemptive kidney transplant if we can see that coming and get it set up ahead of time before they ever need to start dialysis. So we list patients on the deceased donor kidney transplant list when their GFR gets to about the 20s, so before they're ready for dialysis. This is a chart that I try to show everybody that I can about life expectancy. So if you look at the blue bar, the first bar based on different age groups, that's the expected years of life remaining based on your age group for the general population. The purple here is kidney transplant patients, and the pink is a patient on dialysis. And so really want to drive home the point that the difference between being on dialysis and having a kidney transplant for a child, so this main group that we take care of, you gain 25 to 30 years of life expectancy once you get your kidney transplant. And so that's why we are so aggressive about getting patients transplanted for kidneys. We would love to be able to fix this gap here between kidney transplant patients and the general population, and that's going to take some long-term, probably system-level change, but at least in the short term, this is a huge jump, and so that's why we're aggressive with transplant. That's all I have for this overview potpourri of chronic kidney disease. Feel free to reach out to me anytime if you guys want to talk about any of this more or have any questions.